And we'll go ahead and start. People will probably be joining us as we're doing this PowerPoint presentation. And then we ask that if you guys have any questions, just pop them in the chat, and we'll have about like 10 minutes at the end to go over all the questions. All right, so we'll go ahead and start. All right, so our objectives for this PowerPoint is to define human trafficking, understand what it is, the different types, the difference between it and smuggling and prostitution, identify risk factors for HT, and then understand the role of the forensic nurse, the medical forensic exam for victims of HT, and understand what holistic care of a victim of HT looks like. And so I'm going to be referring to human trafficking as HT. It's a little easier and quicker to say than human trafficking. So the United Nations defines human trafficking as the recruitment, transportation, transfer, harboring, or receipt of persons by improper means, such as force, fraud, coercion. They also include abduction in there. We'll go into that a little bit later. And for an improper purpose, including forced labor or sexual exploitation. So another definition that I like to use is that it's basically an exploitation of a vulnerability through the means of force, fraud, or coercion for an individual to commit commercial sex acts or enter into forced labor against his or her own will. And I say exploitation of vulnerability because that is what a trafficker looks for in identifying someone that he can use for this purpose. Anything that the person can potentially be dependent on the trafficker for, the trafficker looks for to use to exploit that person to be able to control what he or she will do. And then this is just a stat on human trafficking. It's the fastest growing criminal industry in the world, generating more than $150 billion annually. So these are the different types of human trafficking. So there is sex trafficking and labor trafficking. Sex trafficking is well known. Labor trafficking isn't as well known, but it's actually, it's the percentage of labor trafficking versus sex trafficking is higher. So there's more labor trafficking that goes on than sex trafficking, but it's just not as well known, not as much as talked about as sex trafficking. So sex trafficking is a commercial sex act induced by force, fraud, or coercion in which the person is forced to perform such an act. Or for minors, if they're under the age of 18, force, fraud, or coercion does not need to be proven. If they're under the age of 18 and they're engaging in commercial sex acts, it's automatically sex trafficking, human trafficking. And then labor trafficking is the recruitment, harboring, transportation, provision, or obtaining of a person for labor or services through the use of force, fraud, or coercion for the purposes such as involuntary servitude, peonage, debt bondage, or slavery. Okay, so here we're going to go over the difference between smuggling and human trafficking. These two can be confused a lot. People think that for human trafficking to occur, the person has to be transported from their home, so from another state to another state, or from country to country, and that can happen in human trafficking, but that does not need to happen for it to be human trafficking. So smuggling can happen in human trafficking, but human trafficking does not happen all the time in smuggling. So human trafficking has to do with exploitation. Crossing of state lines is not needed. You have to prove force, fraud, or coercion. Smuggling has to do with transportation. So ICE defines smuggling as an importation of people into the United States involving deliberate evasion of immigration laws. Like that's the main thing that they're looking for is the breaking of the law. They're coming to either country or state illegally. This offense includes bringing illegal people into the country as well as unlawful transportation and harboring of people already in the US. And then we're going to talk a little bit about prostitution versus human trafficking, because this can be pretty confusing. Human trafficking can happen in prostitution, but there are also sex workers who choose this profession and they desire to be in this profession. So human trafficking, again, involves force, fraud, or coercion. You have to prove those. And then prostitution involves a consenting, willing, or voluntary participant in which a transaction is made with mutual consent. And this sex worker can be doing it independently. They can be making their own ads, making their own dates, or they'll do it through a third party, like an escort service, sometimes they join a brothel, or they go through a pimp. And the relationship can be different, but meaning pimp and prostitute, where they are mutually respecting, but that's very rare. It's really hard to differentiate the difference between a woman who's wanting and okay with everything that's going on in sex, being a sex worker versus human trafficking. And quite easily, even if a sex worker decides to, join forces with a pimp, that relationship can change pretty quickly to become something that becomes oppressive and abusive and ends up becoming human trafficking. So it can be very hard to differentiate, but the consent is the main part. Then we're going to talk a little bit about the choice of prostitution, meaning that a lot of women, when they make this choice, they don't see any other option. A lot of the women who do choose prostitution, they're like, well, I did it to make quick money because I couldn't really do anything else. Like I needed money quick. I needed to be able to provide for myself, provide for my kids. And so they chose that because they felt like they had no other option. And so when you think about it like that, is it really a choice for them to engage in this? Many times our patients that come in, even if they are doing prostitution, they're like, I don't really want to be doing this. I don't want to be here, but I have to. So there's a huge, it's very difficult for victims of human trafficking, but sex workers as well. So both victims of human trafficking and prostitutes, sex workers have public health and legal problems. They have difficult access to care as well as lack of control of the work environment. So like I was saying about the pimp, that relationship can change pretty easily. Their clients can be very violent as well. We've encountered victims who endured abuse, not just from a pimp but from clients as well. Or, they're walking the street and they get robbed and mugged. So it can be a very violent occupation. And then they also have lack of legal support. There's, a lot of bias, there's misunderstanding, people think that it's just wrong, they shouldn't be doing that. They don't listen to the story as far as like why they're in that place. So there can be a lot of bias. And then what we do when we encounter patients, whether they are victims of human trafficking or victims who are engaged in prostitution, we make sure that they're educated. We give them as much information as possible as far as what's happening to their body, anything they may be at risk for, as well as resources. So we make sure that to try and get them connected into advocacy services, just so that they have that support, and then they can feel that they have opportunities to choose, whether they want to get services here or whether they want to leave and where they can go. So it's important to educate, and that is empowering. Okay, so this is just a model that is used to identify as human trafficking is occurring. So like I said earlier, the 3 force, fraud, and coercion must be proven in an adult victim to see if it's human trafficking. But the 3 means is action. So basically what causes that person to get into human trafficking, which they can be induced, they can be coerced, they can be abducted. And then through a means, either force, fraud, or coercion for the purpose of commercial sex trafficking or labor trafficking. And then, like I said earlier, with the minor, you don't need to prove force, fraud, or coercion. If they're engaging in sex acts, it's automatically considered human trafficking.
So this is the power and control wheel, and this just really shows the why of why the victims are remaining in these circumstances, because from the outside looking in, at times it can be easy to just maybe try to rationalize why they're staying. And you may even think in the back of your head, like, why don't they just leave? Because it's a lot more complicated than we may see. And because of this power and control wheel, that's what's at play. And so not all of these pieces have to be used in the circumstance with the victim, but at least several of them will be used with every single victim. So a couple of them that are here: intimidation, emotional abuse, isolation. So they're getting them away from their family, their friends. They don't have anyone else, so that automatically brings control over them. They will deny, blame, or minimize anything that they're trying to bring up, any feelings that they may have towards a situation. Sexual abuse is normally very common, especially with sex trafficking. With labor trafficking, it's not as common, but you cannot completely just throw it out, because it is a possibility even with labor trafficking. There's also physical abuse. They'll use their privilege. There's also economic abuse. A lot of the patients will come in and they don't have any money. they won't even have like ID or anything because all of it's been taken. So they have no other way to make money for themselves. So they always revert back to the same circumstance and situation. And then also coercion and threats. So like I said, not all of these have to be used every single time, but you'll have at least a couple of these pieces of the wheel at play with each of the victims to see why the person had that power and control over them in the first place. So as Angela was mentioning earlier, force, fraud, and coercion, those are the means of human trafficking. And so these are some examples here listed of different ways that the victims will end up in these situations. One of the most common is false job advertisement, especially those who come from other countries. They will either be talking with someone online or have some sort of communication with someone here from the States, and they will promise them a better job, better career, better money for their family. And once they arrive, they realize it's not anything like they thought it would be. Some of these people are also, or some of these victims are also sold by their families, whether for drugs, because their families being trafficked themselves. There's a lot of different reasons why, but being sold by their family is a common reason as well. Lover boy, they may think that they're just here to be in a relationship with someone. They've met someone online. Now it's super easy these days to be able to communicate with people from all over the world. So they're having these opportunities to speak with people and think that they're going to come here for a romantic relationship. And once they arrive, they realize it's not that case. Abduction is also, it's not as common of a way, but it is a means of bringing a victim into human trafficking. They also can be trafficked by a friend, and they also are offered the opportunity of false immigration. So as this picture says, he promised me a place to stay, then forced me to work as a prostitute. Very common thing that we'll hear among our patients. It's just there was some means of fraud that was involved. So who are the traffickers, right? Who are the people that are putting the victims in these situations? Honestly, it can be anyone. A lot of times we like to think that it's people from a certain economic group or from the low income side of town. It comes from all over. The perpetrators span across all ethnic, racial, and gender demographics. And some of them will use their power, wealth, and privilege as a means for control, but some of them also come from the same socioeconomic status as a victim. So they really just, it varies from case to case. It also can be intimate partners, restaurant and farm owners, powerful corporate executives, government representatives. The span is wide and they can come from all different sides of it. Oops.
Oh, there we go.
Uh-oh. So I'm not going to read through all of these for the sake of time, but these are actual examples of different traffickers that we have, or these are stories from the victims of them describing their traffickers. So let's just go through the first one real quick. All the names have been changed for the sake of patient confidentiality, so none of these names are actual victims' names. So the first one, Jennifer was going to meet up with a friend. He took her to this building, put something over her eyes, then put her in a car. He drove her to another building. She had no idea where she was or what was happening. She heard a girl screaming, and then she was raped. She was sold to 13 different men who did whatever they wanted to her. If she didn't do what they wanted, they would physically assault her. She was finally able to escape. She was finally able to escape and go home to get help. So that's just one example. She knew the trafficker. She gave her trust over to him and was manipulated. I won't read through the entire second story, but it says Lindsay first met her pimp when she was 12 years old. He took her to a different city, and that was the first time he raped her. Her family found her, and she stayed with him until she was 19, where her pimp came back into her life, and she decided to go with him to pursue what she thought was a relationship. This is going back to what I just said in the previous slide. They think that it's something that it's not. She's trusted this person. She's let him into her life, and then it becomes something else. So like I said, abduction is common. You can have someone just snatch someone off the street, but it's not the most common way that victims are trafficked. Most of the times it's from someone they trust, someone that they've let into their lives, and then that begins to take advantage of them. So once again, these are just some of the different risk factors of patients that are vulnerable. As we mentioned before, there's different things that play a part, and the power and control will really preys on the vulnerability of the victim. Poverty, homelessness, substance abuse, sexual abuse, child abuse, if they're runaways, if they've been involved in the foster care system, if they've been victims of domestic violence previously, if they're part of the LGBTQ community, if they have mental health concerns, or if they have just some other type of maybe suppressed trauma. All of these things come out, and the traffickers can see those things and they prey on those things. Victims that are the most at risk are for those that are runaways or that have been in the foster care system. Sometimes they age out and they have nowhere else to go. They're no longer living in the foster care homes, and then they're out on the streets. The traffickers can see that vulnerability, and they try to fill that void by essentially grooming them. They try to tell them that, oh, it's going to be a better life. I'm going to get you a job. I'm going to get you this, to get you that. And then they realize that it's something that it's not for them. So just real quick, these are just other graphs from studies just showing who is vulnerable. And as you can see here on the first graph on the left side, 14 to 17-year-olds and 18 to 21-year-olds are the most at risk for the time that they are first introduced into this commercial sex act industry. A lot of times those are the runaways, the ones that are aging out of the foster care system, involved in maybe even misdemeanors or different, rebellious stages of being a teenager, and the trafficker will prey on to that. And as far as recruitment methods, the most common recruitment method is romantic situations or marriage proposals. Going back to the other slide, when we mentioned the lover boy, they think it's going to be a simple just relationship, and it becomes something far more complicated than that. And as far as demographics go, females are obviously at most risk, but there are male victims as well. Latinos are the most common group of victims that are populated. It's the most common ethnicity that is trafficked in this in the studies that we've seen. So vulnerability does spread across all ethnicities, all races, all ages, but these are the most common ones. And so as far as where does trafficking occur? So just to hit on the hot spots, these are the most common ones. So we've heard of escort services. So these are the ones that we are more biased to think that, oh, they may have a choice, but sometimes they don't. Illicit massages, health and beauty, they'll be presented as just a massage spa, but then once you arrive into the facility, you realize that there's other services that are provided. There's often, the victims are often illegally here and they have been trafficked over or smuggled over to get here. Remote interactive sexual acts are also another means of trafficking. So these are the live stream, the webcams, phone lines, text-based chats. We also have outdoor solicitation. So that's what we know as like the most common form of prostitution, which is like walking the streets. Essentially, you may hear it labeled as tracks or strolls, trucks, rest stops. Those are very common areas. Also residential sex trafficking. So within residential communities, the brothels, the private homes, drug distribution homes, these are all ways that the victims, or these are different methods that the victims will be trafficked. And last but not least, bars, strip clubs, and cantinas are also very high areas for victims to be trafficked. And just real quick, just another quick graph. For cases of sex trafficking, escort services come in at the highest. And some of the other top ones for sex trafficking specifically are outdoor solicitation, that's walking the streets, residential sex trafficking, pornography, which leads to all the different ways that the victims can be trafficked, and personal sexual servitude. So that's kind of having your own, essentially in layman's terms, like your own sex slave. Cases of sex and labor trafficking combined, the highest form of that is seen in illicit massages, health and beauty, like spas, that's what we spoke of. And then you can see the different breakdown as far as cases that are specifically just labor trafficking, including domestic work, restaurant services. So the list goes on, and you can just see what the highest is, how they work together, and then ones that are separated out.
And just how many different areas it can be in. It can
Right.
really be anywhere. It's not just one specific place.
Right. Uh-oh. That's why I gotta go one.
Yeah. So here we're gonna go ahead and transition to the healthcare aspect of human trafficking, like how those two intersect. So human trafficking is considered a public health issue. So about 55 to 88% of victims of human trafficking have come in contact with a healthcare professional. Healthcare areas, whether it's a doctor, whether it's ER is a really high one, or just some type of clinic. Um, Victims of human trafficking frequently come in contact with some type of healthcare professional. And the awareness of human trafficking, or even what to do whenever you encounter human trafficking as a healthcare provider, there's not that much education. So people really don't know what to do when they interact with a human trafficking victim of someone, and they don't even know how to identify. So in 2012, there was a study that only 6% of healthcare providers reported treating a victim of human trafficking in their career. 57% of survivors on Polaris' survey, which is a site that gives a lot of statistics, and they operate the national hotline, the sex trafficking hotline, and they gain their data from there. They reported never being asked human trafficking or abuse assessments questions during their visit. And so you can see this graph here on the bottom right. So the dark blue line is all the calls that were placed to the hotline for the year between 2007 to 2017. And then the light blue line on the bottom is healthcare provider calls to the hotline reporting human trafficking. But so you can see how over time from 2007 to 2017, the lines have become closer together. Now that human trafficking is kind of being broadcasted a little bit more, there's more awareness, there's more education, there's a lot more help happening now. People are noticing like, hey, we have to get healthcare on board. We have to be able to educate. We have to be able to tell them what to do, so that way we can get these victims help. And so thankfully there is awareness going on. There still needs to be more. We do visit a lot of ERs as nurses here, working with TX Stephanie, and so it's really great to be able to educate the staff there and talk to them. And they're literally seeing these patients who come in for different reasons and say sex trafficking, and then or say sexual assault, and we're able to talk and find a sex trafficking component and be able to educate them on that. So it's been really good. So now we're going to go into the role of the forensic nurse. So what we do is we conduct officially a medical forensic exam for the purpose of diagnosis and treatment of the patient. We're there to make sure that the body's okay, to see what's going on, see how we can make sure that they're taken care of. So we divide it between acute and non-acute. So this is in terms of evidence collection. So for acute patients, that means less than 120 hours since the last incident, or 5 days from the last known incident of HT or sexual contact. So it doesn't necessarily have to be a sexual assault. It doesn't have to be that they were with their pimp. It could be anybody. So if they saw a client like 2 days ago, we'll still collect evidence, even though that was technically a client. If it was human trafficking, we'll do it because it technically wasn't consensual. And then non-acute is over 120 hours or past 5 days. That we'll still see them. We won't do evidence collection, but we'll still look over the body, look for injuries, take pictures, and then just evaluate them medically. So if a patient is not already known to be an HT victim, we ask questions to identify if a patient could be a victim. So we use a human trafficking identification tool, and we just ask these questions to all of our patients, especially the ones who are maybe at risk for it, that we know based off the vulnerabilities that we talked about earlier. We make sure to ask these questions just to see if they could be a victim. And sometimes we've identified based off that, and that was really crazy to say that if we didn't ask, then they would have just left, not having received those services. And then being able to connect patients with advocacy. So while we're doing the medical part, we also make sure that they have a safe place to go after we're done with them. We evaluate for safety, and then we connect them to advocacy for counseling services, if they need shelter, or anything to continue their continuity of care. So now we're going to go over a little bit about the presentation of an HT patient. So we look for suspicious tattoos. So like sometimes we'll show some pictures later on, but like crowns is a really common one that we see. Sometimes they have barcodes, money signs, or BB, which it's technically, it's called bottom bitch. That's what they use to call the madame of a human trafficking operation. So basically, sometimes there's a pimp and there's multiple women who that pimp has control over. There's a woman who he trusts to be able to do the work for him. If he's not there, if he's engaged in something else, then she will keep the other women in line. So that's who the BB is. And so sometimes these patients also have multiple phones, no access to ID documentation. So we look for those, and then as well as they may be open to very open with their explanation. They may be talking about what they experienced, or they can be very hesitant. And so we'll see that if a patient's like ready to leave, they'll tell us everything. They'll tell us everything. We don't have to ask. They'll like tell us the names. They'll tell us all of that. But if they aren't, or if there's other elements of power of control, like if she has a child with this person and the child's at this person's house, or within control, that person has control of the child, she's not going to want to get out because she wants to make sure her kid's safe or anything else. So they can be very hesitant. They won't say anything. Something's going on. They were caught red-handed in this, but they don't want to say anything. So you just kind of treat them as a person, treat them as a patient, make sure they're taken care of, and educate, educate, educate. And then if law enforcement's there, we see them as more hesitant. They're more suspicious of law enforcement, and then using different verbiage. So even if they're being hesitant, they'll say these words, and like they've been involved in this kind of lifestyle, because they'll say like walking the track, turning tricks, getting tricks, which is basically like getting dates or having clients. Walking the track is like walking the street. Walking the blade is another one. And then we see runaway youth is another vulnerable population, a really big vulnerable population actually, but we see most common with their presentation is that they're not as cooperative, that they can be on drugs. Substance abuse is huge in this patient population, and it also is a vulnerability that was exploited in the beginning to get them under the traffickers' control as well. And then lack of support system. They don't have anyone to go to usually. And then is the victim able to move freely? Does she owe money to the employer or hold wages? Just asking questions like that, or also just being aware of that. If she's talking about that, then you kind of red flags going off that something else is going on here. And then we're going to go into the physical, behavioral, and environmental indicators of HT. So there's a lot here. Feel free to look over it. But some of the main ones is that these victims, they don't have access to care. Usually they're forced to work, even if they're on their period. They have to shove up tampons, shove up socks, shove up whatever to make sure that that's taken care of. And then they keep working. If they have any pain, as long as they're physically able to walk, they still have to work. So usually if the patient comes into a hospital or to ER, they have delay, like the progression of the illness has progressed so far that they need like immediate care, whether it's sometimes with STDs or just lack of gynecological care. They can develop pelvic inflammatory disease, which is very serious and needs to be taken care of, or they have injuries there that haven't been seen, or they're just their physical health is not on par. It's not great. They also can have signs of long-term trauma. So I would say more than physical, like emotional, just they're more hyper aware, they're more focused, they're asking questions, they're very vigilant. They can be malnourished. A lot of times they aren't fed. They're having to work multiple days without eating. I had a patient the other day that was 3 days and she hadn't eaten anything. And then also substance abuse is really huge. So, they have signs of withdrawal, or they're, needing some type of, I had a patient one time who was requesting help with the drugs because she was on drugs, she's coming off, and she's scared of the withdrawal symptoms. Poor hygiene. And then specific to labor trafficking is severe workplace injuries that haven't been taken care of properly, prolonged or unprotected exposure to toxic chemicals, severe exhaustion. And then specific to to sex trafficking is STDs. A lot of times the patients, they'll come in requesting STD medications or just to be tested, because that's the main thing they're concerned about. They can have multiple pregnancies or reporting multiple sex partners. And that goes into the bias that we see a lot of times in healthcare, is that like, oh man, she's just coming in all constantly for this treatment. She's coming in constantly for STDs. What is she doing? We're treating her, but she's coming back reinfected. And so she needs to actually listen to what we're telling her, but it's like she can't because she's being forced to work. So there's a behavioral and environmental. So behavioral, if they're not really ready to talk, you'll hear scripted stories. It sounds very like they're just telling you a tale, but it's not really the truth story. Minimizing abuse or minimizing injuries. Like I saw like clear bruises or clear abrasions on a patient, like, hey, what happened there? It's like, oh, I just slipped and fell. And it's like, you don't get that from slipping and falling. Or, oh, I was dancing and I hit some wall. And you don't get that from doing it. So a lot of times they don't want to talk, they don't want to share it if they're not ready to leave. And so they'll just minimize everything. They can be overly fearful, very vigilant, like I said earlier, unaware of location, date, time. Because they don't really need to know that. They just know that they have to get out and work. being unwilling or hesitant to answer questions about injury or illnesses, inability to focus or concentrate. They can demonstrate compliance if they're wanting help, if they know that they're safe to leave. If they don't feel that they're safe to leave, they can be very resistant to assistance. Like, no, just give me the medications and let me go. Or they can demonstrate hostile behavior because they don't want their safety to be put into jeopardy. Suicidal ideation, suicidal attempts, PTSD is huge, depression is huge. They may leave against medical advice. So if they find out that you're kind of like getting onto them, that you're asking these specific questions, sometimes they realize that like, oh, this lady knows, and then they'll get up and go because they don't want to be in trouble with their pimp. And they may refuse care. And then sometimes environmental factors, so they can be accompanied by someone, so the pimp will not let them out of their sight. So if they need prenatal care, if they need like medical care, if going to ER, they'll have a pimp, which can be a man and it can be a woman. And we've heard one time that there was a woman who brought the victim in and posing as a sister. And the victim was the nurse could tell that the victim was very hyper vigilant. Like she was looking at the sister before answering, and the sister was answering everything for the patient and not letting the patient talk, had control of the ID, had control of paperwork. So that set off red flags, and so they asked to separate them. And then they were able to talk to the victim one-on-one and get some answers and find out that they were actually a victim of trafficking, and that was it was a BB. And so so that's a huge environmental factor. And then also report high risk environmental factors such as living at their places of work, working in crowded environments, and not having a fixed home address. And then
So this is a little bit of the breakdown of what we do as forensic nurses in our forensic exam. You've heard us mention it a couple times by now that, oh, okay, we do a forensic exam, but this is a little bit of the breakdown to give you an understanding of what we do for our patients. This is a breakdown of what we do for all of our patients. And then we're going to discuss what it looks like to take care of a human trafficking patient, because it's going to be a little bit different. So obviously we have basic consents. We go through demographic and medical history. With this is sometimes when we get some of our first indicators that the victims are in trafficking. Like Angie just mentioned, they won't be able to give us a home address. They say, I don't have anywhere to live, or I'm kind of all over the place right now. I'm in between places. Some of those are key terms. When they get to the medical history, then they disclose that they've had quite a few pregnancies, quite a few abortions. That can be sometimes an indicator, not always the case, but these are just things that can be indicators. They also will just say that they may have had quite a few STDs in the past. Then we move to the history. As Angie mentioned, depending on where they are in their progression of being in the life, as they say, they may be willing to tell us a lot, they may not. So it just depends, and we go off of what they say. We do human trafficking identification tool for all of our victims. This just makes us aware of the victim as a whole. We want to make sure that we're not missing anyone. We're not just overseeing anyone, because if they're in our care, that's the perfect opportunity for us to be able to work with these victims. We also do a physical exam looking for any injuries, documentation of any injuries if noted. And we also do an anal genital exam. So looking down at their genitalia area, looking for any signs of trauma, but also any signs of any sexually transmitted diseases. And after we do the assessment part, we also provide STD testing, and we administer medication. So in the medical term, it's called prophylactic medications. Essentially, we are treating them as a just in case you've gotten any sort of sexually transmitted diseases. Let's go ahead and give you a one-time dose. And if anything comes back positive, we'll see if we need to continue with medications moving forward. We also do discharge education and safety planning, and we'll discuss what that looks like to be a little bit different for our victims of human trafficking. So how does it look a little bit different? We do the assessment as normal, as much as we can, as long as the patient allows us to look at their body for any injuries. Then we move into what we call a modified exam. So as we mentioned, they may not give us much in the history, so it's going to be a brief history. Sometimes they only want to tell you a little bit about what happened, and they just want testing and treatment. They don't want to do the evidence collection, which is part of our exam. I believe I forgot to mention that, but when we're doing the physical exam, as we're looking for injuries, we also do evidence collection if it's within the 120 hours. So that's collecting for DNA. They may not want to do that because of fear of retaliation of their pimp, fear that they're going to get them in trouble or something along those lines. So they may just want to get basic treatment and leave. They may allow the physical exam as mentioned, but no evidence collection. And the patient still has the right to consent to whatever part they want to and refuse consent to other parts. As far as diagnosis, so we do nursing diagnoses to just kind of really see where the patient is at. Ineffective coping is one of the big ones because they haven't really been able to process everything. And so they may not present in the way that someone would if they've really healed from trauma. So they may come off very hostile, very angry, very sad, withdrawn. They may cry the whole time. The symptoms that present will vary, but a lot of times it all goes back to the underlying diagnosis of ineffective coping. Also, safety is of utmost importance with these victims. If they're ready to go, we have to be very vigilant in how we relocate the patient. We have a lot of great community partners that we work with when victims of human trafficking do arrive at our facility. And so if the patient says that they're ready to leave, they don't want to go back, we try our best to move them to at least across county lines, if at least, or at least to a different city. Houston's pretty big, so as long as we can get them out of Houston or at least to a different part of Houston, then that's one of the first steps moving forward. But safety is of utmost importance. So that means that we're asking them if they have phones, turn their phone off, remove any location. I'm just doing anything that we can for these victims. Also with treatment, a lot of them don't have insurance because they haven't been able to have a steady job or be able to acquire insurance in any way. So follow-up care can be sometimes a hard thing for them. Even just following up with them can be hard because of their situation, and they may not have a phone the next day. They may not even want to answer. They may be off the grid for a couple of days. So following up can look a little different moving forward, but we try our best to get some sort of reliable contact information for them. But once we test them and treat them, we do know in the back of our heads that there is a chance that we may not be able to follow up and have any further contact with the victim.
Okay, so what's next? So during the exam as well as after, but especially like honestly when we first walk in that door, we're trying to build a relationship with that patient. We're trying to make them feel comfortable, make them feel a little bit of trust towards me, that I'm there not just to do what I need to do and get out, that I'm there to listen, that I'm there to make sure that they are taken care of holistically, like mentally, physically, emotionally. So we work to build relationships and rapport with the patient during and after the exam. So like just even making jokes, just talking about other things, just making them feel like, hey, like she just wants to talk to me. And then that can help a lot, just to getting information from the patient, being able to know what's really going on to be able to better take care of them. So we also work to follow up with the patient for STD testing or treatment. Like Stephanie had said, we do treat them when we see them. And then we also do testing. We try to follow up with them. A lot of times they'll have maybe an email, or they'll have something, but if they don't have anything, any way of us following up with them, we'll give them our number and then just ask them to contact us as soon as they can if they want to follow up with us. We also make sure to let them know that, we're there for them, that we are not an extension of law enforcement. A lot of times they think, oh, you're doing evidence collection, you're with the police. It's like, well, no, like we're different. We're here to make sure that you're okay. We're here to make sure your body's okay. So we make sure to reiterate that, because that's just like another wall that will come down. And then like Stephanie had to talk about safety planning. So we make sure to do that towards the end of the exam. We also can connect them to legal advocacy, just to, if they need like protective order or any type of other legal help, we make sure to try and connect them to that. And then we also just make sure to listen to them, empathize with them. Like, they let them talk. Sometimes they're talking about, they'll talk about the history, but then they'll talk about all this other stuff that happened that's not related, but we just let them talk and listen. And it's really good. Like, honestly, I feel privileged to be able to work at like that, because when we're there, we just focus on them. Like, we don't have any other people, anything else. We have unlimited time to be able to just listen. And that's really helpful for them, but also helpful for us to be able to do that and be able to provide that quality care. And then we listen to patients' concerns and work to address what is most important to them. So sometimes it's not, oh, I want to get out. And sometimes it's like, hey, I need to get an ID. Or sometimes it's like, I need to like get counseling, or I want to find a clinic I can go to. And so whatever they feel is they need, we'll try and connect them to people who can help provide that. And then we also schedule an FI if needed. So that's a forensic interview. So usually we see that more often with patients who are ready to leave, who want to be out of the life. we connect, we work with law enforcement for that. We have a forensic interview program at TXFNE, and what they do is an adult forensic interview program. And what they basically do is they ask more in-depth questions, more investigative questions about the situation, about what was happening, and they try and get names, they try and get locations, colors, all that kind of stuff, and then it'll help the investigator with finding out more information for this patient's case. And then, so basically what's left, like, so this is what we do and what have we noticed that needs to be done in order to better our ability to care for these patients. A huge thing is that there's more need for HT related research. There's not a lot of sources that can provide reliable research. A big one, like I said, was Polaris, and they basically go off of the hotline, and as well as their other services that they're able to interact with these victims. But there's a lot of underreporting. There's a lot of missed victims, and so it's difficult to make research. But there's not a lot of data collection which can make identifying like the holes and stuff like that harder. And then, like I said, scarcity of reliable and comparable research. And then education and awareness. So like we saw with the healthcare chart, is that from 2007 to 2017, with education, with awareness, the calls and tips to the hotlines was increasing in the healthcare environment. And it's continuing to increase, which is great because we're able to get these people help. But some other high traffic areas is hotels, social media platforms is increasing. It's an increasing venue for sex trafficking, but it's also just increasing in general in our culture and our community. So it's really important to be able to get that information out there on social media platforms to be able to educate the public, but as well as people who might be using that site to know, like, hey, like this isn't okay what's happening to me. So I can call this number, I can do this, as well as rideshare applications. So a lot of our victims do use Uber or do use Lyft or do use something like that to be able to get from date to date. And so being able to educate people who are working in these areas to know what to look for, know how to identify, and even just be educated in general about what this means, as well as community awareness. So churches and other faith-based organizations are pretty big in wanting to help in this area. So and there a lot of the tips to the hotline does come from public and does come from people who are engaged in these areas and know what to look for. So continuing to educating these people who, and as well as homeless shelters and advocacy agencies, as well as substance abuse programs, because like we saw with our high risk victims, is that, you know, people who are homeless, people who are dependent on drugs and stuff like that are higher risk for human trafficking. So educating people who volunteer, who serve in these areas is gonna help to be able to get these people connected. And then as well as family and general public education. So like we saw about foster care system, a lot of our patients have aged out of the foster care system or are currently in the foster care system. And so educating families and to know, like, hey, like these signs, these symptoms are what to look for if, and know that something's going on with your child or with your kid, I think. And even just especially connecting with social media platforms, like educating families and parents on what to look for, different sites where things like where exploitation can happen, and just educating how to have conversations with your children to be able to ask these questions and be able to know like what's going on. And then just general public education and awareness. And then this is our human trafficking identification tool. On the bottom right, you see it says Bureau Institute of Justice. So there's a full length human trafficking identification tool that they created. And what we did is we took that and we modified it to be able to ask like the main questions that we felt like were broad enough to be able to let the patient just speak, and but as well help us identify if there's something going on. And so we are able to use this with our exam. So it's already about a 2-hour exam. The human trafficking identification tool from the Bureau Institute of Justice is very long. It takes about like an hour or so, but they are very thorough with their questions. It's very helpful to be able to know what to ask in order to identify if something's going on. But yeah, this is our tool we were talking about that we use to identify if there's any human trafficking going on.
So real quick, just before we wrap things up, just wanted to give you guys an example of an actual victim. This was actually my patient. And essentially she is like textbook what we see for human trafficking. And so I'm just gonna read through it real quick. And obviously all names have been blocked out for the sake of patient confidentiality. As we read through it, we will just see the different components and we'll break it down. So I asked the patient, can you tell me what happened that brought you here? She stated, I'm a victim of human trafficking. I've been a victim for the past 2 years. My husband, sorry, we have something black. My husband gave me to the man who's been using and selling me. He sold me to him for drugs. I have been raped I don't know how many times in the past 2 years. I can't even count it. I'm here because I was able to escape. Today I was raped by two guys, one Mexican and one Salvadorian. The Salvadorian put a gun to my head. He raped me. Then he put something in my vagina. I haven't slept in 4 days. I haven't eaten in 5 years. I feel something inside of me so sharp. It's cutting me up. Stuff happens every day. If we're not with clients, we're cleaning, cooking, treating him like a king. That's what he wants. Blank has my child. He's the father of my child. He won't let me see my baby because I don't know what will happen. Blank is torturing me because he wants me all for himself and I don't want him. In Cuba, I met a man and he's my boyfriend. Blank thought that we had sex and now he's selling me more than anyone else. He's saying that I will never see that man again. That man's name is Blank. I can't leave Texas until I find my child. Blank has her right now. His sister has her. She's in on all this too. God only knows what will happen if he finds out that I called the cops and that I'm here. I'll never be able to forgive myself if he does something to hurt her. So that's just the basic history that she gave me. I probably should have given y'all a warning. It is a little graphic. And moving forward, there is some graphic content, just as a heads up. So a couple things that we can see here. She's been in this situation for the past 2 years. So it's been an ongoing thing. She was sold by a family member for drugs. She's been raped countless times in the past 2 years. So you have the element of being sold by a family member. That's the means. You have what has been happening, and that has been the sexual abuse. Let's see what else. She hasn't slept and eaten in 4 and 5 days. So that lack of sleep, lack of eating, that really plays a role in this too, because it's controlling her. She's trying to do anything she can to survive at this point. And then she also has the element of isolation. He won't let her see her child. He doesn't like the fact that she has a boyfriend back in Cuba. So this element of like, you're for me and only me, that really plays a part. And we see that time and time again. So I asked her a couple questions to clarify, just for the sake of diagnosis, treatment, where to look for injuries, where I should be looking for evidence, how many persons' evidence should show up, so these are different things that we're asking, one for us, for our sake, but also for the sake of the crime lab as they're analyzing the evidence. So she gave me a little bit more of an understanding of what she's been doing with these guys, what they have her to do. And even I'm just going to skip down to one of the final questions. I asked her, how was she able to escape from the situation? Because she was saying that she was with the Johns, or with the people, that her last clients, and then she ended up at the hospital. So I wanted to understand what had happened. And this is for the means of safety. And she said, I snuck out when they were shooting up heroin. This actually plays a part too, because we'll see moving forward that they try to inject her with her heroin as well, which is once again another form of control for the victim, bringing drugs on board. Most times it's the trafficker that supplies the drugs or involves them in drug situations, but the clients or the Johns can actually be a part in this too. So I added in this is the body diagram from the injuries that I noted during the exam. You may not see it as much. There's only 5 injuries here, but even then there's still quite a bit of things that are at play. So just starting from the injuries that are on her arm, those are all different bruises. And in the middle of the diagram, you can see the patient states, all of these marks on my arm are from them trying to inject me with heroin. And so this is just showing that they were trying to bring that control over her. If she was under the influence of heroin, they may have tried to possibly re-engage in sexual acts with her, or who knows what they would have wanted to do. She also had point tenderness, which means that if you touch a certain area that the patient feels pain or tenderness, or is a little sore there. So she had point tenderness right in the middle of her chest area. And she said, he kicked me in my chest. She was referring to her pimp. That's the physical abuse side of things. So not only is there sexual abuse involved, there's also physical abuse from the pimp himself, another means of power and control. And then on the back of her, like right on the lower part of her neck area, upper part of her back, she has a tattoo of the pimp's name, which we'll see in the next slide. And that is a very common thing that we'll see with the victims. They'll have the tattoo somewhere. A lot of times they were not forced, they were forced into this. They were not wanting to get this tattoo, but the traffickers see it almost as in a sense of branding. because human trafficking is essentially modern day slavery. They use this as a means of branding the victims. A lot of times they'll have tattoos in random spots, so that can be an alerting thing too. They'll have them on the inside of their lip, and just spots that are not the most common for tattoos, which can alert you that there may be something else going on. So this is her with the pimp's name on her back. And just once again, that they'll often use the tattoos as a means of controlling the victim, letting her know like, hey, my name is on your body. I own you. Some of the tattoos will literally say like such and such property. There's a lot of things that can be a part there. And just going through the pictures real quick, this was some of the bruises that were on her arm that I documented on the body diagram. We do photo documentation as well as body diagram documentation. Once again, she stated, these are the marks from them trying to inject me with heroin. And you can see on the pictures that you can see essentially the puncture marks of them attempting to. She said the only thing that really saved her is that her veins aren't the best as far as, like showing up really well. So they had trouble with it, but that is something that is at play. Oops, okay. So this is the evidence collection page. This is straight off of our chart. This just shows what we collected. And essentially, all of it doesn't necessarily need to be discussed right now. We normally collect our underwear. We collect anywhere that there's evidence. One thing to be noted. So the patient did state there, I feel like something's inside of me. This was one of the tougher cases that I've seen. There was actually a tube of toothpaste that was shoved into her vaginal area that I had to remove during the exam. And so, although graphic, this really just shows the reality of the abuse that can occur. Sometimes we only think of punching or slapping or maybe even like pistol whipping, but there's so many different ways that the victims are abused in these situations. And so this was the slide. This was the actual picture of the toothpaste that was removed, and the bottom part is straight off of the chart. She complained of the intense pain in her vaginal area due to the foreign object that was forced inside. And so then once I removed that, then I moved forward with my exam to just see if there was any further injury there due to the nature of the assault. So that's just wrapping things up. Hopefully you were able to learn some things from this. Now we are going to take some questions. And so here, let me just stop the share. Let's see what we got. Okay. Let's make it big and now all right, we see some questions here.
All right, so let's see. If you encounter a patient who's being human trafficked, are you legally bound to report it? So with minors, yes. If they're under the age of 18, you need to report it. Even if they don't want to get out, even if they're very adamant of like, I just want to go, I don't want to be here, I just want this, you have to report it. But if they are an adult, it's their choice. Sometimes, I had a human trafficking patient that wanted to be non-report just because she was afraid of the retaliation. And you have to respect that because they're an adult, they're consenting. All you can do is just educate, let them know what resources are available to them. And it is honestly a real fear for them to report because there's things that we don't know about, things that they may not share with us about what their pimp has control over, whether it's a child, whether it's finances, whether it's they know where their family lives, anything else. And while we want to believe that the police will take care of you, they can only do so much. They can't follow them around constantly. They can make a protective order, but they're gonna have to, trust new people, and that's just really difficult. So you just try to understand and be there for them, and just educate them. If they do within 2 years, if they want to make a report of it, they can do that. But typically after 2 years for a non-report, we have to destroy the evidence kit. But that chart that we took will always be available for them.
Could you share the HT screening tool? So I think Angie explained a little bit more. It may have been asked before we got to the screening tool. It is available online.
Yeah,
correct?
so it's the Vera Institute of Justice is what we used to look at. There, I couldn't really find much. They have just symptoms to look out for, but an actual tool, it was really hard for me to find. But Vera Institute of Justice was one that I felt like was pretty thorough. And if you wanted to look over that, create your own based off of that, that's really helpful.
Does anyone have a dedicated community response team for women, youth who want to get out? So here in Houston, we do have, thankfully, quite a few resources because Houston is such a hub for these locations. I mean, for these victims of trafficking. So a couple off the top of my head, one is called The Landing. They're dedicated. They work with some of like the minor patients and like the younger population, and it's all about human trafficking, getting them out, getting them back on their feet. So not just getting them out, but getting them restored back into the community on a healthy setting. So being able to get them a GED, get them a job, stuff like that. But we work with quite a few different. So I feel like they're one of like the most common like response teams. We also work with Vice. They also help us out with human trafficking
Yeah.
as well.
YMCA, I know, comes to a lot of our exams as well. So the main ones that we interact with, if it's a minor specifically, is YMCA and the Landing, that they'll come and connect the patients to resources and get them into either to a rehab program or to a shelter or something like that. With adults, it's a little bit more difficult because there is that element of consent. Like, you know, even though you're being forced, like as an adult, it's treated differently. So we'll connect them. I think the Landing's limit is 24, so 23 or 24. But we'll connect them with advocacy agencies. So we'll work with Montgomery County Women's Center. We see patients in multiple different counties. So Montgomery County Women's Center, Houston Area Women's Center, and then we also have advocates that work with us directly just to follow up with them to make sure that they're having what they need. So yeah, those are some of the agencies that we use. So does it include relocation? I'm guessing we're talking about safety planning, maybe.
I think they were like responding to that. That's somebody else's thing. But with our facilities, the Landing and the YMCA, they will work their best to relocate the patient.
Mm-hmm.
Do you have a regional or state network of safe houses or equivalent?
So we I think our advocates definitely like work with other agencies to be able to put them in safe houses. I know there's a bunch of different like along with the Landing, which is a faith-based organization. There's also Elijah Rising and a couple of other anti-human trafficking organizations that have safe houses. Redeemed Ministries, I think, is one that they have safe houses for patients where they can either go and get rehab. But usually when we connect them from our place, after we see them, we'll connect them either to the Landing or to YMCA or to another women's center, which will be able to further evaluate what they need and get them to a safer place. So yes, there are safe houses, there are places for patients to be relocated to, and they can choose, or we try and let them choose. I know that some of these agencies, they'll work, like Stephanie was saying, about getting a GED, giving them skills, basically helping them to like learn other skills and things so that way they can be able to work on their own and work in a different area.
There's one right there. I think you probably know that one. Someone said, what are some of the most pressing issues you'd like to see research on with this population?
Oh,
you like research?
Yeah. I think, let's see.
That's a good question. I think I would like to see like the long-term effects of like of someone who's been in human trafficking, like what that looks like for the span of their life. Once they get back on their feet, or if they ever are able to get back on their feet, like how does that look like for their job, their career, their family, just like what it looks like for them to be like reinstilled into society essentially, and how does that look like long term? I think that'll be one question.
Yeah, for sure. And then I also think just that looking over the elements of power and control, like the power and control wheel talks a lot about what's used to keep these women and children, or even guys and stuff, in human trafficking. Like I don't think we touched on it, but like transgender and LGBTQ is huge as well. Like we see a lot of transgender patients. We had a sting one time where we were doing a human trafficking sting and basically seeing patients after patients, and a lot of them were yeah, and it's difficult. They're just they have like multiple biases against them, and it's just really challenging. And then being exploited as well, like they're even seen as different and lower in this kind of community. So it's really challenging. But yeah, so kind of like looking at research on like we know what the power and control wheel is, but like how can we identify and act on those different elements to be able to provide support in those different elements so that victim feels safe to leave? Because the reason they don't feel safe to leave is because those things are not being provided for. So how can that be? And then another element that's being lightly touched on, but it's very sensitive, is the buyers and the pimps. Usually with pimps and traffickers, there's something, they're not just all evil people. Yes, like, they're doing horrible things, but sometimes they also have endured a cycle of abuse, which trained them and led them to do this.
Yeah.
So it's like figuring out how to reach out to them as well, because if you can get the trafficker, you're not gonna have them. And then also I know there's a lot more research on how to interact with buyers. There's rehab programs with buyers. So like the states, I know the officers, I don't know if they do it here in Houston, but I think I read in another state that there would be like an advocate for the buyers who would go to the stings as well. And so they would meet up afterwards to talk with the buyer and say, hey, like, do you know like what was this? What were you thinking when you were doing this? I was like, oh, I thought this lady just wanted to like, she was wanting to, make this transaction, and that's what I was here for. It's like, well, no, this is actually what's going on. And when they find out what's actually going on, they're like, oh, I don't want to do that. And then they enter a rehab program where they deal with why in the first place did you want to do that. So like, dealing with that brokenness, dealing with that pain that they're feeling to even want to buy and do that kind of stuff. So just kind of working with that is a huge one. So
someone said, I understand much better some of the demographic questions of my advocate and how I can elaborate and question on HT to a question to gather more information. Yeah, and that was I think that's kind of like the goal of this sort of presentation, is to, yes, bring awareness to human trafficking, but also like what can we all do in our own places, in our own environments, wherever we are, to better care for these patients, be more on the lookout for them. Once you know, you see. And if you didn't know certain things to look out for, then you don't really see those things. But now that you've been made aware of them, hopefully that we can move forward. And sorry, that's not it. Where did you get your body diagram from? So we have it's part of our company. I don't know if we can share. I don't know. I will let you know when I found out.
Yeah.
I'm not sure where we actually got it from. I'm not sure.
Can y'all put your contact information in the chat?
Yeah.
No, you. Thank you.
I feel it. If you want to scroll. Let's see. Are we up in CEs or IA? I think we are currently working on an educational curriculum that is literally in the works right now. So we have an online training program for SANE nurses to be a part, but as far as CE and stuff, that is literally in the works right now. So at the moment, no.
Yeah, so if you go to our website as well, I think we do CEs for like the in-person classes for SANE. So we do offer SANE training. So we have like a 40-hour education program. So we'll do like a week where you're coming in for 4 days out of the week, and it's about 8 hours every day, and we'll educate you on everything. It's a lecture. And then we also do simulation. So if you want to become insane, we also do simulation labs, and you get credit for that, as well as, and it is CEs, as well as you can put that on your application for the state certification as well. So all of that information is on our website. It's at, she put txtiffany.com. So you can look at that under education, I think. And then I know that we have been working on an online program. I'm not sure if it's released yet, but if it is, it will be on there, and you just register online and you pay for the classes. And
then, for the same?
Yeah,
that's live. You can do that.
Yeah, and then you do get CEs for that.
So okay, let's see. So I dropped both of our email address as well as the website. So I saw someone that asked about the body diagrams. If we're able to release that, I can email that. Also the power and control wheel that was there. If you email one of us, we can send that to you as well. I'm the counseling supervisor at Fort Bend, work on a sexual assault program. Past 2 quarters, we have not reached our crisis intervention goals, and I'm the one who has to give an explanation as to why goals were not reached. I surmise that fear of the ER is preventing victims from accessing healthcare resources. I was wondering if you could share what you're noticing on your end related to COVID. Really good question. So I think I would like to just hit on the motive of like why our company was even founded. Our CEO saw that there was a lack of knowledge, a lack of awareness, and there was also just a gap with these patients. There was an article that was released that there was one patient that went to 6 different hospitals before she received the care that she needed. And the patients lose trust in the system at this point. They're not wanting to even go through it. It's been a hard day, it's been a long day. They're told not to eat, not to drink, try not to use the restroom, yet they're not getting the care that they need. And so if that was just one patient, how many others were out there that just didn't get a story made about them? And so because of that, the ER does great things, right? We love the ER and we work well with them. We have quite a few hospitals that we have contracts with that we go and visit. But it's just this I guess, in ignorance to the fact that they can come and get the help that they need, or they may have had bad experiences because of ignorance on the healthcare side of things too. And that's why we really just emphasize the importance of awareness from both sides of things, so that we can really do the best care for the patient. Because if the patient comes in and they feel like they have someone has a bias towards them, they're not going to want to come back. So I feel like that's one of the big things that prevents the victims from accessing healthcare, aside from the fact that their traffickers don't often let them go to get help or get healthcare resources and that kind of thing. Just the simple part of they don't want to go because they don't want someone to look down on them. I think that's a big one. And now with COVID, yeah, it just makes everything 10 times harder, as it has for all of us.
Yeah.
Because they don't want to, go into where COVID is, essentially, even though COVID's everywhere, but they don't want to just be in that kind of environment. So
and we noticed, like, in the beginning when the lockdown happened, like, we didn't get, I think it was like 2 or 3 weeks where we got very little calls. And then afterwards, like, it started ramping up again, and actually got really, really busy. Like, I mean, people were just very aggressive to one another. And so it got really, really busy. And then as far as human trafficking goes, like, majority of the patients that we get who are human trafficking either are from a sting or are from like an undercover, like, the police are, they typically walk either Bissonnette or other streets that, where this happens, and they try and make relationships with the victims. And so if that happens, or not necessarily relationships either, they'll just kind of like try and catch them. If they're selling them, then they'll arrest them and take them in. And so if they want an exam, then that provides an opportunity for us to be able to talk to them, connect resources with them. So that's what we've been seeing a lot. Is just majority of the time, that's how we get in contact with HT victims. There's very few that we've seen. I think some we've seen in the hospital, but not as many as with the stings or with undercover operations.
And here too at our facility. And I think one other thing that really hinders the victims from coming in is, as we mentioned, a lot of these patients aren't here legally. And so they don't want to come in because, they're fearing their legal status being at risk. And so when we put out community awareness, when we do any press conferences, anything that we're doing to allow the media to shed light on what we do, we always try to emphasize that we are not here to do anything regarding your legal status. If anything, we're going to try to help you to stay here or anything like that. But we're not here to call ICE. That's not our goal at all. Also, I saw that Carmen de Jesus was from Puerto Rico.
Yeah.
We just went last year. Do you have a special way to give them contact info if their controller is with them?
Yeah. So thankfully, majority of the time, whenever the patient comes into the hospital, they're by themselves. Like, they figured out a way to, either escape or like, hey, I gotta go like run this errand, and their pimp is like, yeah, sure, go. And so we haven't really thankfully had to have contact with them with like their pimp or bottom BB or whatever there. And then also when we see patients at our offices, they're usually brought in through law enforcement. But I've interacted with other nurses and stuff who've had it like that, whether it was like they identified that this was a human trafficking situation. So typically what you do is you try and get them separated. So similar with domestic violence, like I know in the hospitals you have like these questionnaires, and whenever you're admitting a patient and you ask, do you feel safe at home? But like, I think, if the patient's there and they have their husband there who's committing that, they're not going to want to answer that. So usually when I'm going to ask those questions, I'll say like, hey, I have to do some things with this patient one-on-one first. I have to like, this is just a policy. So for this section, you have to step out, but I'll let you come back in after we're done. And then I'll have him step out, and then I'll ask those questions to her. But if he's not stepping out, and you just kind of feel weird, then you can ask, like, you can either ask, like, you just be very firm, and then usually they'll listen, or you'll say like, hey, we have to take her for an ultrasound, or we have to take her for this, and then you take her and move her. It's like, she has to go by herself, you have to stay here. Take her and move her to another room, and then ask questions.
We have tricks.
yeah. So just kind of like try and think like that. But sometimes, like, I've heard one where the nurse asks those questions like, hey, we have to like go and go to this other room, and then they both were a little hesitant. So she was going to get security to help with getting, like, separating them. And then when she was stepping out, they bolted because they realized like she knew what was going on.
Yeah, so we definitely have to be very subtle about it, very wise about it, because we don't want to endanger ourselves or the victim. And obviously if we feel like something's off, we can, notify security or that kind of thing. But we try to just play it off. Essentially, we can, and I feel like in layman's terms, we play dumb. We just act like nothing's
Yeah.
going on, but you've already checked off in your head, like, okay, this victim is at risk. I think something's going on here. If we're in the hospital, you can even alert some of the other people to like, hey, keep an eye out. I'm going to try to figure out what's going on. And then, yeah, pull out all the tricks and stops. Because like we said, this is a privilege and an honor to be able to be with this patient in this time. We don't want to overlook her. We don't want to miss the opportunity for her to go back. Now, if she chooses, him or her chooses to go back, then that's on them. Essentially, that's their choice, but we don't want it to, like, we don't want the blood to be on our hands when we had an opportunity to help, essentially. Somebody asked about the web address for the, I don't remember what it's called.
Oh, yeah.
Institute or something.
Oh,
I see all the nice comments. That was so sweet. Thank you. How do you bill if you are not collecting evidence and they are not reporting to Ellie? Billing. So we do not do the billing.
But I know, like, for so we have a contract with, you know, the hospitals, so we have an agreement for which if we go to the hospitals and we are getting paid by the hospitals to go and see. But what we do is we build the OAG, so the state of Texas, there's, you know, a program that if you saw a patient, even if they didn't make a report, you still kind of get we still kind of check off for those things. And you know, I think that's a little,
yeah,
I know.
still we get to charge them for something.
Yeah, so you get something from, you're able to get, you know, reimbursement for your supplies and stuff like that, at least.
So we do what we can. Okay. Thank you, Kristen. If anyone else has any questions, they can drop them below. I think we got all of them. Once again, y'all can send any emails to either one of us or both of us regarding those the power and control wheel or anything else that you saw on the slide. Kristen, we may be able to send it to you. We can take out the case study part and then send it if that's something that people are interested in, so that they can have something to look back on. We can just delete the case study slides.
Yeah. That sounds great.
We'll do that right now for you.
Yeah. And then I think there was a survey that for this class.
Yeah, so I think they dropped it a little bit earlier, but there is it's in here
somewhere
in between the messages. Yeah.
Yes.
It's an evaluation. So please feel free to do that. Let me see someone any messages. Okay.
Yep, that's it. So yeah, no more questions and we're good.
Thank you all so much.
Yeah,
thank you all for all that you do.
Yes.
Pray that y'all have a great day.
Yeah.
All right. Bye.